In October 2017, it was announced that two of the biggest NHS trusts, the Salford Royal NHS Foundation Trust and the Pennine Acute Hospitals NHS Trust, have come together to create the Northern Care Alliance NHS Group. The Alliance will be one of the largest NHS healthcare organizations in Greater Manchester and the Northwest, serving a population of over 1 million people under a new group arrangement of hospitals and community healthcare services. Minister, distinguished guests, and colleagues, I am delighted and honored to introduce Sir David Dalton, Chief Executive of the new Northern Care Alliance NHS Group, as our keynote speaker this morning. Sir Dalton has been a Chief Executive at the National Health Service for over 22 years, serving at Salford Royal for 16 of those years. He's currently developing, as you have heard, a new integrated care service to include hospital, community, primary, and social care for the city of Salford. Called Salford Together, it represents a partnership between the City Council, the Clinical Commissioning Group, NHS Foundation Trust, primary care, and mental health. The Council and the CCG have also pooled resources and now oversee a combined budget for adult health and social care services. Sir Dalton was knighted in 2014 for his services to healthcare. He was a member of the Berwick Review Group, which advised on patient safety improvements for England. He also advised the Secretary of State on the opportunities for providers of NHS care, including the publication of the Dalton Review, which recommended actions to ensure the delivery of high-quality healthcare through sustainable organizations. He established the Northwest eHealth and currently serves on the National Review, advising the Secretary of State on IT and digital developments. Today, Salford Royal is one of 12 digital exemplars in NHS England that will pioneer new practices and best practices in digital skills and technology in a bid to improve patient care. A thought leader himself in quality and innovation, Sir Dalton is a governor of the Health Foundation in the UK and founding chair of Advancing Quality Alliance, NHS Quest, and more recently, HALO. HALO, with its strategic partners in Salford, is an innovation and improvement science center with expertise in digital connectivity and capability development. We are most delighted to have HALO, Salford Royal, and Sir Dalton join our CHI co-learning network. In his keynote today, Sir Dalton will be sharing about leading change, innovation, and improvement in healthcare. Please join me in a big warm welcome for Sir David Dalton.
Minister for Health, Professor Eugene So, his distinguished colleagues, ladies and gentlemen, thank you so much for inviting me here for this conference. I'm looking forward to hearing other speakers and sharing learning. And in that regard, about sharing learning, I've already learnt two things. One is that I probably don't have an ulcer. And second, I probably should prevent my dog from licking me in the future. So I thank you very much for the learning that you've passed on already today. So, am I in control of the slides, or is there something to move? Thank you very much. Point up there. Thank you very much. So, as Professor Eugene So has said, I am Chief Executive now of an NHS group. It's in the northwest of England, and you can see in the red there, it comprises a component of Greater Manchester. So the blue area are the 4 localities that I have a responsibility for: Salford, Bury, Rochdale, Oldham, and North Manchester. You'll see some of the statistics of the dimensions of the role. I'm very pleased that one of those care organisations, Salford, it has been determined as an outstanding organisation in our NHS rating system. It's only one of 10 in the country. But what we're trying to do is to bring together the hospital services, community services, primary care services, social care services together in an integrated and single governance form. But before I continue, some of you will know the map of the country, but let me just show you this is another slide view, and I can see Eugene already is pointing to Manchester United ground, Old Trafford, where I thought when he came over to visit me, he was actually coming to visit me, but I realised there was a game that Manchester United were playing, and that was probably the real reason. But I want you not to look at the football ground, but to take your eye up right into that top left-hand corner there, just here. This is Salford Royal. This is the one of the hospitals up there, and this is the Salford Quays that's been redeveloped, Media City, where the BBC and other media companies are in the country. So normally when I lecture, I talk about quality improvement with a focus on patient safety. For this talk, I'm going to move off that theme and talk about the wider picture of change and innovation, and want to reference what I think are some of the unstoppable forces that we are all experiencing. And it's the role of leadership to make sense of this, to navigate organisations and their staff, and to seize opportunities that are presented. So we know, certainly my experience of healthcare has been very much, I think, recognising some of the inertia that exists in the provision, where the patient came to the hospital, where the physician or clinician was always present in that interaction, and normally there was a diagnosis or there was an intervention that was prescribed. And now we have this continuum, and we see that both where patients receive their diagnosis or their treatment, or where physicians or clinicians are located, and the nature of that encounter is changing. Now, I'm not sure in Singapore where you are on this continuum, but I think all developed healthcare countries are seeing change happen quite significantly. And with that change come these new dynamics with new opportunities, which digital, telecommunications, precision diagnostics, and the support that can be given to clinical decision makers. This is changing very much the way in which we organise ourselves and manage the business of improving the healthcare of our populations. Now, for me, and I'm sure for many of us, one of the enemies of improvement is waste and variation. Now, if you look in my own area in Greater Manchester, you can see the extent to which we experience variation, where we believe that if the best systems in Greater Manchester were able to, if all systems in Greater Manchester were able to operate at the best, we would probably see nearly 2,000 fewer deaths, 2,000 more lives being saved. We'd probably be able to accommodate tens of thousands more patients within our organisations. And you can see that there is a job to be done. That if we are to make the improvement, then we are to tackle the variation that exists. Now, my interest and my presentation today is going to be focused in these four areas here. How we can identify the best and standardise and seek to replicate that and spread it at scale. How we can organise integrated services across the systems that we manage. How we utilise the opportunities that digital presents to ourselves. and importantly, how we can support our workforce through this change. So let me begin. This was the value proposition, one of the first slides that we used in our organisation and spoke to others about creating the Northern Care Alliance. We believed that there were ways in which we could harness some of the changes that were happening around us and to provide a persuasive and convincing case that we could deliver value. And I mean, when I talk about value, about how we can improve the health of our population and also improve their experience. In this talk, I'm going to have a particular focus on digital and what that means, I think, for us and where we are on our journey on embracing digital in our health and social care systems. But let me begin again at the formation of the group, which is covering about 1 million population. Our concern has been how we can identify best practice and seek to spread and replicate that elsewhere. Now, I mentioned Salford, which was deemed by our National Health Service as being an outstanding organisation. Well, there it is, but it's surrounded or adjacent to these 4 other localities. So the nearest hospital to Salford is North Manchester, has some very good people working there, but it had been assessed as providing inadequate services. It's the lowest rating that our country can give any one of the hospitals. And that rating was also given to these other hospitals here. So the job that we took on was how we could take some of the best practice in Salford and beyond, the best that we could identify nationally and internationally, and bring that into those other localities. So we created the concept of the group. The group is not about having a mega merger. The group function sits above and beyond the delivery. So we have 4 healthcare organisations, and they have a responsibility for delivering services. My role and those of the colleagues who work directly with me is to support them in doing that by determining the strategy, by determining how we invest in buildings and facilities and equipment. But most importantly, it's about determining the standard operating model by getting that best practice into all of those organisations. So when I mention the standard operating model, these are the components of it that we are giving our attention to. So how we govern and how we support leadership, how we identify that best practice, codify it so it's appropriate for replication, and we do that by being clear on the standards of service that we deem appropriate. And then the area that I want to talk to you about is digital health enterprise. And we describe this in four activities, and I'm sure that much of this is familiar to you as well. We want to be able to engage with the people who use our services. We want them to be part of the organisation of their own care, and we want to be supporting them in doing that. We are also interested, as you are, in how we can achieve greater productivity through automation. We want to be able to optimise the facilities and the capacity that we have. We're doing that through the concept of the control centre, which I know that you're developing here as well. And like many organisations across the world, we want to be supporting our clinicians in their decision making. So we, as I heard Eugene mention, have been awarded the accolade of a Centre of Digital Excellence, and we have been assessed by our National Health Service as being the most digitally mature organisation in the UK. We have an electronic health record, as the Minister was talking about. Our health record is unlike that you would find in other parts of the UK. It is fully integrated, so our primary care and our hospital care systems talk to each other. We're embracing that now with social care onto having a single shared record. We collect our data through consensual arrangements for sharing that, so every general practitioner, every primary healthcare practitioner can look at the shared record across the system. We're also developing this now across the whole of Greater Manchester, so that every hospital, every GP clinic, every community clinic, every social work interaction, every visit to the pharmacist is also included within that data connectivity in a system called Data Well. So we are developing with our staff an approach, and there is so much that you can do in this area. And so we are having to be selective, and I'm not wanting to overstate our position. We are early in this journey. We are not as advanced as many around the world, and I'm sure in this country as well you will be able to take me to places that are further advanced. But we're wanting to proceed on many fronts and to do this simultaneously, but do it in a way where it's acceptable to our staff and that they are embracing this change with us. So we have selected the areas with our Chief Clinical Information Officer and also our clinical information officers, which are found in each of our clinical directorates, to be able to design supportive systems that can work for them. And that we're doing this through an approach which is not to digitalise the whole of the care pathway. Our view is that would take us too long, as interesting as it will be, and I'm sure that we will do that eventually. But rather than that, we're seeking to identify actions that will have a real impact on health issues, and to cluster these around particular health conditions and sharing those protocols that can be utilised to support our clinical staff in their decision making. There are many examples of how this is being used, and for this presentation, just a couple here, of looking at supporting clinicians in their decision making to standardise the process, particularly where we know that we are reliant upon our doctors in training to take decisions. And so this is just demonstrating how through prompts and through the use of the health record we can get them to request their scans for patients reliably, and how we can translate this into patient benefit by reducing the number of days that patients here have for low molecular weight heparin treatment. So we're seeing how we can support our staff in their decision making, but we're also seeing how we can support patients too in the decisions that they make about their lifestyle. So we are working with an industry partner, with Hitachi, to develop a new way in supporting our patients to take their lifestyle decisions. And these are people who have been identified with impaired glucose regulation, and how we can help them or prevent them from progressing to type 2 diabetes. Now, this is an approach that I'm increasingly seeing adopted around the world by using coaching. But in this particular case, what we're trying to do is to give active feedback to patients in the moment and at periods of consultation with their health coach. We're able to identify these patients as well using digital, so we know where all of our patients are in our system who have particular health conditions. We can ask the GP to contact that patient, and we can invite them to participate in programs. We can then give them contact with a health coach, supervised by clinical staff. But what we are doing here is also shifting the cost of providing this treatment. So our coaches are administrative staff rather than clinical staff. and the cost of the service and the productivity of the service has changed substantially. There is more that we will do in this area, but for us it was our breakthrough moment when we enabled this particular design through digital and giving people immediate feedback on the choices that they make. I mentioned the control centre. Now, this is a vision of the future, is not the position at the moment. But I cannot see how we will be organising healthcare without using the data that is available to us, and about understanding where our patients are and the interactions that they have with the health and social care system. We are at a very early stage in doing this, and when I visited last year, I observed the progress that you're making in this area too. But I think that it will be in the years to come, probably after I've exited the stage in my career, that the new leaders of healthcare systems will be viewing how they support people, and most particularly out of hospital, but how they can organise the complexity of healthcare delivery in a very different way. So we're clear about how we're going to build and develop this. We are, as I said, a very early but encouraging stage in the development of our control centre. We're working with colleagues in the ambulance service so that we can be using their information in real time as well. We're able now to allocate tasks to our key medical staff, particularly our staff in training. We're prioritising the work for them and asking them to do things perhaps at a different time frame from how they would do that in order to increase the productivity in one of our hospital systems. Now, the reason for doing this is not only for providing better care and reducing length of stay, but there is a clear financial benefit that is derived from this change. So our business model that has been accepted is that we will drive out of our system over a period of 8 years, cumulatively in excess of £50 million. That is what I've committed myself to. I stand in front of you making that bold statement, and if you invite me back in the years to come, we'll see whether I've been successful. Now, this change is extraordinarily difficult for all of us. We're familiar with using technology in our homes, in our work, in our cars, but when it comes to doing a job ourselves, we know how we've done that. We know the way in which we have been trained and educated, and the way in which we practice. When the opportunities come for digital to be changing the way in which we undertake our roles, it's extremely uneasy and provocative in terms of the anxiety that staff have. So we are working with them and supporting them through this change. But we are seeing this as a major shift in the way that we organise our workforce. As we know that we will probably be requiring fewer staff in the functions that they currently undertake. We will be moving tasks from people who we pay a lot of money for because of their educational attainments and their proficiency in their practice to other staff at lower grades. We will be using data to be highly disruptive in the way that people organise their working patterns, and we'll be expecting them to be responsive to that as well. And we will be asking of our staff a higher degree of flexibility in the way that they make themselves available to us every day and every week as we change their allocation within the hospital they work or in the community that they work. And this is asking an awful lot of our staff, and I will I know in a later session be talking about how we support the workforce through what is a monumental period of change for them. I'm going to shift tack now and just talk a little bit about the Salford Together project, which is the first of its type in our country, of bringing together the hospital, the community, the mental health services, the primary care services, and social care as well. So I have a responsibility for all of the budget, all of the funding. So we purchase nursing home care, we organise the care in people's homes, the hospital care, mental health services. All of that now is governed in one organisation. And the area that we are most interested in is frailty. And understanding this not in the way that I have before, in the episodes of care where people come into hospital, they have a diagnosis or they have an intervention, and we transfer them back from whence they came, and then just a few weeks later see them once more. This is looking fundamentally at how we can shift the place in which care is provided from out of hospital into their home or into their neighbourhood. And recognising that at the moment, approximately 2/3 of the patients in the hospital system are aged over 75. And so we know that we can do something different. And we know that many of these patients who are frail have multiple long-term conditions. And this slide here illustrates the proportions of those conditions that people will have. We know that this is going to be difficult for us to do, as it is for any healthcare systems. But we're working together with our colleagues from the city. Our partners are listed here that Eugene referenced. So all of these people have decided that they will give up their sovereignty, their responsibility that they had, and they will share that in a new governance model. And that they will allow one organisation to take the responsibility that they once had vested in themselves. So the organisation that I led, Salford Royal, has been selected as that organisation to govern the whole of the health and social care system in Salford. And so what we're attempting to do is to move away from the fragmentation that you would ordinarily see when different organisations, different agencies have a responsibility, however well they do it, and they did do it very well. This is no criticism of those different agencies or organisations, but however well they did it, there were boundaries, and at those boundaries were our problems. And so the Integrated Care Organisation is now attempting to develop care packages which are bespoke for individuals and which are delivered in our local neighbourhoods with the very clear intention of being able to offer and promote preventative measures and to secure as much independence as possible for people who are experiencing frailty through their multiple long-term conditions. So this is what we've created: one system, one budget, bringing together all of the components of healthcare and social care. We found mechanisms to do that. People said that it couldn't be done and that the law prevented it, but we've managed to work our way around that to unite all of these different agencies and organisations together into one system with one governance and one budget. I should say that, except that we are still working with colleagues in primary care. By the end of March of next year, we should have agreed our path of convergence. So they are alongside us, but not yet under a single system of governance. But within a few months, we will have agreed how we do that. We've taken an approach which many have chosen to do, and that is to look at our services not through the lens of the provider, what it looks like to us, but to work with families across the city to understand their life experience, and particularly those who are the most vulnerable, those who are our older citizens in the city. We've been working with them to identify their issues, their experiences, the problems that they have in navigating the health and social care system that I have a responsibility for. It's difficult, but we are blessed with some wonderful stories that people have given us. They are very demanding as well for the improvements. And we have, now looking through the lens of my organisation, been working through a process of identifying those people who are likely to require more help from the health and social care system, as well as identifying those who are currently well and independent and who we need to ensure that they maintain that way. This is a change of mindset, though. It requires us to, although we have a lot of importance here, mostly in our hospital-based systems, but the mindset is to shift now for people like me in leadership positions to think that this is not the only area of importance. Being able to help Sally, who was our old lady who we were using as our example, being able to help Sally to stay well has become as important to me as it is managing the complexity of our hospital-based systems. So Salford Together is about bringing not only organisations but neighbourhoods, communities and the assets in those communities which have really no direct contact with health and social care. So these are community groups, groups that might be found and organised through churches or through voluntary organisations, through activities that take place in shopping centres and so on. It's to make connections with the assets, the community-based assets, which we find in all of our localities. To develop the concept as well of the multidisciplinary group, so not unknown to any of us, but this is about organising at a neighbourhood level how we blend the practitioner skills of all of our staff, whether they're social workers, general practitioners, our community-based staff, into a group where they're not only sharing information about that neighbourhood, families and individuals, but they're also sharing leadership as well, that we no longer have each of these different members of staff having different lines of leadership and hierarchy. So we're blending that together in our neighbourhoods, and we're also creating this concept of the Centre for Coordination, the ability to be one place where people go to navigate through the complexity of the health and social care system. So this point of contact. Now, at the moment, these are in variable places, but increasingly we are giving information to people about how they only make one call to one phone number to get access to all of their services. Much of this is organised through the integrated record that I mentioned. This has a longevity now of about 15 years, so we are familiar with how we can use the data in the city and share that with our staff. Now, it is early days, and I don't want to say that we are seeing encouraging results in all areas. We're not. These are very stubborn issues if we want to see improvements in health and less reliance on the cost of providing services. But already in the neighbourhoods in the city of Salford, we are seeing some really encouraging signs now. A reduction of the number of attendances into our emergency department, and importantly, a reduction in the number of attendances and then the number of admissions following an attendance in the emergency department. Now, this is unprecedented. I have not seen this before in my 16 years in Salford. Every single year I could show a rise in the number of attendances and the number of admissions, and it helped me in persuasive arguments with ministers to allocate more money because we were seeing more patients. This is quite different now. For me to go and say, we're actually seeing fewer people in the emergency department and being admitted. I've got to find new ways of being able to record and express this because it's still costing us as much money to support people out of hospital. So we do need different mechanisms, and our country hasn't yet found the way in which we can reimburse organisations like mine who are piloting different mechanisms. We're still paid for the number of treatments in hospital, and we've got to find a different way of doing this. However, if you are a patient in Salford, something different is happening. You are getting the support that was not provided to you in the past. Your condition is not exacerbating in the same way. You're not requiring access to hospital care. So we are spreading this now from an elderly population, and that's where our focus has been, to the whole of the population. And we are doing this through the concept of talking to the people about how we support them throughout the whole of their lives, of starting well, living well, aging well. And we're just about to introduce something that I hope we can talk more openly about, and that is dying well. So we will be having conversations with our communities and people about those concepts. Now, at the heart of this, I mentioned the neighbourhood, and I don't know what neighbourhoods mean to you. Maybe they mean different things. We're talking in Greater Manchester about localities where people have a sense of belonging, and these historically, there is history to where people belong, and the growth of towns and areas associated with cities. But we're seeing that a population size of about 40, 50, 60,000 is what we would call a neighbourhood. It's a geographic size, it has a sense of identity and place, and we can identify the community assets within that neighbourhood, and we can organise the delivery of out-of-hospital care in that neighbourhood. So this is giving us a different concept to organise and govern the services within the city. We're working alongside our staff as well in the changes that we are making. We are reliant on them. This isn't about the leadership of an organisation suddenly having a great idea that we're going to shift and do something radically different. much of the change that we are experiencing is coming from staff themselves. There is a latent enthusiasm that we can tap into, and to get them to be helping us in developing the ideas, organising for themselves some of the changes that are necessary. So we need to reciprocate and offer that support back to individuals, to teams, to larger groups. And this is a really important component of what we're doing. Staff have to believe in the change that we're going through, and it has to make sense to them, even though there is a lot of unknowns, and that we're asking them to be quite different in the way that they work, and to be flexible. Now, my next slide is one that I use as a theme normally when I talk about quality improvement and the focus that we've had on patient safety. And the areas in which we have developed an interest and expertise in organising quality improvement are the same areas in which we are taking forward this particular large-scale change programme. So let me just mention these to you, because I think they should resonate, and they will demonstrate to you, I hope, the importance that I make on the way that we organise to deliver our change and improvement. The first of which is leadership visibility. So often said that the currency of leadership is what leaders pay attention to, and I absolutely believe that if somebody like me says this is important, and then staff hear me talk about other things, or not be interested in what I've said is important, then I might as well go back and shut my office door and not talk to anybody. So for us, it's always been important that the senior leadership is engaged with its staff, that is working with its staff. I still spend a day a month. It's not very much, I know, but I work alongside staff as to all of the directors and senior managers in the organisation. So it's taking me to new places to work with our community-based staff as well. And it's always fascinating to hear what they're saying. Second, often when you're embarking upon change, you can see the complexity. You look forward, and all that you see is odd shapes through the fog. And I think that's okay. I think that one of the dangers of leaders is that they try and simplify things too much. I'm not talking about communications. Having effective, simple communication is important. But if you dismiss the complexity of the change and try and simplify it too much, then you're really missing those things that are going to be impediments to the change that you want to pursue. But if you're going to change it, you've got to measure it. You've got to be clear about what you want to change, how much change you want to see, and when you want to deliver it by. So we attach huge importance to measurement and to supporting our staff in measuring what they're doing and seeing whether that change works. Hugely important is recognising that the higher up in the organisation that you go, the less you really know about the detail of what has to be changed, and how arrogant it would be of me to say to staff, this is what you must do. So we work very much with the concept of that the expertise is deep inside the organisation, and those are the people that we have to encourage to get involved in our change programmes, to give their ideas for the change that they will be experiencing themselves. What do they want to improve? What gets in their way of doing the best possible job to improve the experience of their patients or the people that they're working with? So we encourage our learning collaboratives as our approach to do this. And this is the way that we've organised the large-scale change in our integrated care system as well, organising collaborative learning across staff groups in our neighbourhoods to exchange ideas, to test those, to see whether the changes they're putting in place results in improvement or not. This is new onto the slide, but is important as well, that when we can see what works, we need to be able to codify it if we're to replicate it. Now, this is not something that I've had a great deal of experience of. I've done my job in my organisation. It's been easy to see how to introduce change within that organisation. But I now have a responsibility for 4 care organisations in different parts of the region. And if we see something that works in one of them, how do I take that and move it into another? It's really difficult. I stand before you not knowing how to do this well. I find it one of the hardest elements of how you share learning and implement it reliably. And finally, the issue of teamwork. This cuts in so many different ways, vertically, horizontally, diagonally. You know, I'm sure, everybody who sits in this room, that you're able to do your job only by the way in which you interact with others. So in our programme of supporting the workforce and building their capability, this is what we give importance to about behaviour. It's not just what people do, it's how they do it. It's how they are received by their work colleagues, how they live the values of the organisation. So teamwork is something within our large-scale change programme we have had great focus on. I can see I have 1 minute and 45 seconds left, and so I'm now on my last slide, which is to just to conclude and say I'm really grateful for the invitation to be here. Thank you very much. I am really looking forward to the next few days where we can share learning. I realised that 9 or 10 years ago, I'd been about halfway through my job in Salford, that I had blind sides and knew very little about quality improvement. I think I now know much more than I did before, but I think events like this are so hugely important to open your eyes and ears and to be able to share learning. So I wish everybody here all the very best in your endeavours, and thank you once again. Thank you.